Das ist grün, dann ist aktiv.
Ja.
Und dann ist relativ nah. Aber das will jetzt schnell. Vielen Dank.
Gut. Danke Ihnen. Tschüss. So, hello to everybody to our second poster session today. So, we will have, it's difficult with IT here. So, today in the second session, we will have 5 presenters speaking about their project or national efforts to implement ICF. And I'm really happy to introduce Kai from the University of Medicine and Pharmacy in Bucharest. The floor is yours.
Hello, everybody. Thank you very much for the invitation, for accepting to present our poster. It's actually an older idea of a PhD student of mine. Together with him, he's actually a medical doctor who also studied law, and he at this moment has a company that protects the rights of medical doctors in Romania, because the laws that accuse medical doctors in Romania are much more developed than the laws that protect medical doctors in Romania. So actually the idea is from almost 10 years ago, because we had a very notorious case of malpractice in Bucharest. A quite well-known surgeon cut a very important organ of the maid. Actually, it was his resident, but the responsibility was of course, of the surgeon, of the principal surgeon. So it was a very mediated case of malpractice, and the person who was injured by the malpractice case had actually a very shameful big amount of money because of that malpractice case. So the question is, in our case study, if you want, is the ICF capable of scientifically quantification of moral damages in malpractice? So we know that physical damages are easier to be quantified than moral damages, because we have body functions, body structures that are quite easily assessed by the physical examination and by different lab tests and imaging. But what about the moral damages? Because the patient is really affected by, in his personal intimacy, by a case of malpractice. So if in a lawsuit you have no qualified personnel to be called and to judge the importance of the lesion, of the moral lesion and of the physical lesion, which is the case now in Romania, the judge can only emotionally quantify the suffering of the patient. And as is usually in movies and in reality, the suffering of the patient is expressed by the lawyer, and some lawyers are good, some lawyers are better, so the compensation is related to the skill of the lawyer. So what we did in the use of ICF is we took media article of a person who suffered a malpractice case. And this is the media article. And we tried to assess using the ICF and the qualifiers of the ICF, and we tried to assess what body functions were affected, what body functions were affected, where activity and participation were affected, and we tried to give some qualifiers. And what we saw in our case study is that ICF can really be a good tool to assess the limitation of activity and restriction of participation in a malpraxis case. So we thought of further investigating this approach, and he's now in his my colleague who did his PhD is now investigating this type of approach in his law firm, but there is no official means of using the ICF in lawsuits. Anyway, the main problem that we encountered is that actually the ICF does not have qualifiers and does not speak about personal factors. And even if we can quantify the limitation of activities and restrictions of participation with the ICF, we still have a big gap to evaluate the personal factors. So in conclusion, I think the ICF is good. The ICF has to evolve a little bit also to take in account the personal factors. And we think that ICF can also be used in judging the moral damages in malpraxis lawsuits. Thank you.
So thank you. Are there any questions? Yes, please.
You mentioned the personal factors. Do you have into the personal factors classification?
No.
Just repeat the question for the people listening.
If we use the classification that has been proposed for the personal factors, this is a study that was a case study that was done 10 years ago, and I don't think that the classification for personal factors was valid at that time.
Thank you. So we will come to our next presenter. It is Volodymyr Golik from the presidential administration in the Ukraine.
Ladies and gentlemen, dear colleagues, thank you very much for accepting my presentation for oral one. And I'm happy to be with you and to discuss our problems. So we are starting to build the modern rehabilitation system in Ukraine since 2014. Since the beginning of the war on the eastern Ukraine, due to fully collapse of Soviet-style rehabilitation system in Ukraine by wounded soldiers. So next year we won a jackpot. So the jackpot was the rehabilitation advisory team come from WHO and International Society of Physical and Rehabilitation Medicine and provide a technical consultancy which is consisted of examination of existing rehabilitation system and developing the recommendation how to move forward. And according to this roadmap and according to this recommendation, we are currently moving our process forward. So logically, the basic recommendation was to establish and to approve the Ukrainian translation of basic rehabilitation terminology, which is not existing in Ukrainian language. You can see disability, functioning, occupation, activity, and participation, as we can find during our discussion with colleagues from Eastern European countries. This is the same problem in different other countries. As well, the issue is to translate ICF as it is to Ukrainian, as well as to develop and translate ICF-based tools and to test and to do following issues. In 2016, it was issued several state documents concerning the ICF implementation, starting from the special directive from Acting Ministry of Health from December 2016, the order from Ministry of Health, which is establishing the working group, the real multi-sectoral working group for implementation of ICF. You can find it was 25 persons, including parliamentary deputies, all 3 commissioners of Ukrainian president and government, which is rehabilitation of servicemen, to right of people with disabilities, the representatives from Ministry of Health, Ministry of Social Policy, Education and Science, Ministry of Defense, professional NGOs, and due to the activities of this group, some blockage from Ministry of Health advisors, finally, in the end of last year, the directive from Cabinet of Ministers of Ukraine was approved, and it was the approval of action plan. Then during the last several weeks, Ministry of Health issued again 2 orders, the action plan from Ministry of Health and the order to create another working group. But Ukraine is features that a lot of laws may be issued, but they are not executed. A lot of papers may be also issued, but they can be lost, then be blocked. So that is the situation in our country. Finally, we must exactly translate ICF from English to Ukrainian. Exactly, we must perform the initial ICF trainings for Ukrainian population for different stakeholders. We must change the Ukrainian rehabilitation legislation. Currently, we are performing this situation. We are pushing to the parliament the new law for rehabilitation, which was also advised by rehabilitation advisory team. So we also must provide the implementation of ICF educational modules to undergraduate education for MDs, PTs, OTs, and other kind of therapists, to implement 2 postgraduate modules for PRM physicians. By the way, we are developing the OT specialty in Ukraine from scratch. We have 1 OT currently. The same situation is for PRM physicians. We also retrain all existing rehabilitation ones to novel specialty. As well, we must translate and implement ICF-based tools, and we must implement ICF-based principles for collecting data on disability and rehabilitation to receive the international comparable data. Because if the WHO and UN asking Ukraine to provide the disability statistic, we can also only provide the statistic of certified invalidity, as well as in our neighboring countries. And finally, we must move all scientific investigation concerning rehabilitation on ICF basement. So, as a conclusions, we are starting the wide cooperation with international organizations, but we must announce and we must understand such kind of prerequisites to be aware of. First of all, we must ask our international partners to verify all documents on all declared activities, because our advisors from Ministry of Health, our advisors of Ministry of Health are very big declarants, but the documents are not follow the declarations. So we must involve real stakeholders. The stakeholders is not the advisors appointed 2 months ago to lead the rehabilitation directions. So we must involve in real professionals which are aware of what rehabilitation is. So we must start in strategic issues, starting from rehabilitation terminology. We must start from realistic Ukrainian situation. We don't know just for now how to change the financing of rehabilitation. Currently, we do not have the insurance medicine system in Ukraine, and we are only starting to develop it from the primary level. Exactly, we must map full existing regulatory field, which is very networking, and as well use realistic intersectoral approach. Thank you very much.
So thank you for describing the situation in Ukraine and the plans. Are there any questions from the audience?
Yes, the time scale.
Yes.
That's a huge one.
Sorry?
The time scale, how long do you expect?
So the time scale is depending of the intensity of blockage of our moving forward, because, for instance, the period of time between the development of action plan for ICF implementation and the directive from Cabinet of Ministers takes 7 months. It can be closer, but it is our local situation. It's not for, but we all must understand the situation. But with such a side situation during the workshop, we decided to create some kind of consortium of Eastern European countries which have the same problem. So joining Bulgaria, Romania, Poland, Czech Republic, and to discuss the situation. We have a lot of same problems. Thank you.
Involvement of disabled.
Exactly. So we are strongly support the position that this process must be included as well as providers and receivers and customers of service. So we have the National Assembly of People with Disability. We have 2 presidential commissioner, 1 commissioner for people with disability, another commissioner. I'm advisor of the Commissioner for Rehabilitation of Auto Service. As well, we have the commissioner of Prime Minister or government for the right of people with disabilities. So we are cooperating with 3 of them.
Thank you.
Thank you. So now I'm happy to introduce Annabelle Martins, and from the Department of Physical Therapy at Coimbra. Sorry. Please.
Well, first of all, I want to thank you for the opportunity to be here and present this small part of a study that is started in Coimbra, in the center of Portugal, but fortunately counted with several colleagues from around the world, and we could at least bring some results that are important, in my opinion, and our opinion, to start maybe a discussion. This work that I'm going to present is, as I said, is part of is part of a study. We have this poster and we have another one. This one is the 30 and the 40 posters were complementary. They are discussing here, we are discussing here the results about the English-speaking countries, answers. And the other poster was the Portuguese-speaking countries. Much easier because there were just 2, Portugal and Brazil. But anyway, it's, I would say, something that started about 3 years ago, is concentrated in the physiotherapists. However, as I realize still today, that physiotherapists are very involved in the ICF, and as a multi-dimensional profession, I think we can show you some interesting results. So when we talk about physiotherapy object of study and what we say as our core of knowledge, we can describe that physiotherapy is the science of the movement, and the movement system is included in the function. So movement system and functioning, there's some things that are together, and we try on this study to identify first what physiotherapists think about movement system and its relation with functioning, and if it fits the diagnosis process in physiotherapy. Actually, the literature shows us that the diagnosis in physiotherapy is a result of a clinical reasoning process, where when we can identify what is present concerning impairments, disability, or I would say activities and participation limitations and restriction, as well as the facilitators and the various in the personal and environmental factors. The purpose of this study was to try to understand. It was not a very strict. It was a qualitative study. It was not a very strict. It was more an exploratory study, where we ask the PTs in I can maybe it's easier now, where we can we ask them to talk after they characterize themselves about demographic and clinical experience and academic level. They ask an online survey where we ask them about what do they what was their main intervention area, and at the same time what kind of diagnosis do they have they used to do during the clinical practice. We ask them two examples of diagnosis, and we registered this text that they write, and we got from the English-speaking countries 250 answers from 27 different countries, mainly women, but it's quite expected because there are more women than men as physiotherapists, with in average 10 years of experience. And from their answers, we have two different experts on ICF that analyzed the answers and linked their answers to the codes. We use the ICF codes, and at the same time we also we use it because we were expecting that they we used also the ICD-10 because we were expected that some of the answers could fit with to that classification. Actually, the results are very expressive regarding our expectations, and from the 451 examples of diagnosis that we could identify in their answers, about 1/4 were uncategorized answers, so we couldn't understand exactly what they were talking when they talk about or they say about diagnosis. About 100 or exactly 129 were linked simultaneously to both classifications, and 93 of their answers were linked to the ICF, and more 115 to the ICD-10 codes. The majority were in the body functions, the ones that are ICF codes categories, body functions, and only less than 5% were activities and participation. No personal or environmental factors could be identified. In conclusion, we would like to at least stay here and get your feedback if possible. What could be, what could justify this? Because we were talking and we apply in our diary on functioning, but we don't write and we don't think as functioning are the main topic of our profession. So there's a long way to go ahead, and I would like, if possible, to have your feedback. Maybe not today, not in this moment, but in the future. Thank you.
Thank you, Annabella. Are there any? One question, yes, Ola.
Yes, thank you, Annabella. It's really interesting and showing that still to be done. I wonder, did you assess the knowledge about the ICF in the respondents? How familiar they were with the ICF?
Yeah, we have only a small question, and it's self-reported online, so we don't know exactly. It's not the first. It was they know about ICF. We couldn't afford about the intensity, but they say, yeah, and actually we ask about functioning. So we induce them to think about functioning. We didn't say about ICF, but we talk about functioning and movement system. But no, there's no. Yes.
Thank you so much for your presentation. I'd like to know what do you think about this kind of sense of categories for this type of diagnosis? A set of categories.
I'm not going to answer by myself, just because we still are analyzing the other questionnaires, because we have in total more than 700 answers, and we could just get more two-thirds of them, and categorized by English and Portuguese speaking countries. We missed Spanish, and we still have 1/3 for Spanish. They say that they would prefer, because it was another question, they prefer having a list with the opportunity to join more categories by their own. This is what I just want to tell you by now.
Thank you. Thank you. So our next speaker is Mariette Tornensen from De Factum in Aarhus.
Yes. Thank you. Actually because we made this study together. I'm Marissa Thomasen. I'm an instructor at training and I work at the Station in Denmark. Yeah, and I'm an occupational therapist by training, and I'm head of SANU Center in Aarhus. That's an inpatient rehabilitation center for patients with complex rheumatic diseases. And we would like to take you down to micro situations of using the ICF because we've been looking at goal setting and using the ICF as a framework for an analysis of the goals. Yeah. So we've looked forward to coming here today. Last year I was asked by Sano to research on their practice of goal setting. There are Sano Denmark and patients that go to Sano for 4-week program. Each patient is assessed following the components of ICF by an interprofessional team. Goals are set, and then you have an intervention that is based on the assessment and the goals. And then, of course, there's an evaluation, midway evaluation, and also an evaluation. And this is from weight, an evaluation at when we end. My research on goal setting was based on these questions. How are goals set and articulated, and how do goals travel through the intervention? What are patients' and professionals' reflections on goal setting regarding the importance, the visibility of goals, meaningfulness, and also the dilemmas? So how do you actually study rehabilitation goals? I gave that a lot of thought before going to Sano. But I opted for the one option that I have as a social anthropologist. I went native, so I was hospitalized and stayed at the 3 Sano centers for some time, following live 24/7 at the centers. Thus, I followed goals both in action, in speech, and also in writing. And my main findings were that goal setting is very, very often a messy affair. How many here have tried to set goals? Yeah, you know. I think it's the same in most places of the world. I've checked in different places. It's often a messy affair because it's a bit of a detective work. What is actually your goal? That's not very easy. So some patients are confused about the meaning of the word goal. Others are not used to think in terms of goals. And also there's often a clash of expectations where patients, they expect professionals to be experts telling them what to do. And today you might say that you, as the experts, you kind of expect the patients to be a co-expert, but the patients don't really know that they're expected to be co-experts. And also patients, they talk about body function goals, and professionals, they talk of goals at the activity and participation level. You get my point? Get my point. There is a clash sometimes at these sessions. So professionals worry. Do we manipulate to an extent that it becomes our goals rather than the patient's goals? The patients that I interviewed, they express ownership to their goals. That's very lucky. Very lucky. Okay, and another finding was that I found that goals were entangled all parts of the process of at Sano for 4 weeks. When I came, I expected to dig into all the sessions of setting the actual goals, but I found that goals were present in all parts of the process at the Sano, and also that there was a kind of a circularity to goals, because in the end, all the professionals, they asked about the future goals. Okay. And then one of my last points is that professionals had an assumption on nature of goals, saying ideally rehabilitation goals aim to ease functioning in activity and participation, but in reality, so all professionals assume the majority of goals are set at the level of body function. So of course we have to test that assumption, adding on a bit on my study. So we analyzed the goals of 33 persons. Those were the persons that I had followed. So they were not taken in randomly. They were the ones that I had already followed and made interviews with. And they're aged between 24 to 80 years. And then there were about 3 to 7 goals per person. So the 2 of us, we analyzed the goals. We each linked all goals to the 2nd level of ICF. All in all, we had 36 different ICF categories. Then we compared
our linking, discussed where we didn't agree, and then we consensus. So the professional assumptions were wrong, which was very happy about. And 96, that is 69% of the goals were within the components activity and participation. And the four most
commonly used categories were looking after one's health, walking, muscle power functions, energy functions.
Which, when you talk about rheumatic, people will complex rheumatic problems, that's not really a surprise. So the written goals were formulated in very different ways. They differed between each of the three sale locations, but they also differed within teams at each of them. We have pointed out two goals to illustrate our findings. Open and close bra, and being able to stand for more than 30 minutes a day to enable me to participate in cooking with my husband. The bra goal is modulated by professionals to be short and to the point, as well as where the cooking goal is long and puts the patient's spoken words on paper. The dressing code is impersonalized, but others, like the cooking goal, is written in first person. Here both goals are concrete and easy to access, as other goals more reflects the continuous challenge of being severely ill with a chronic disease, and they're categorized as personal factors. It could be learning to accept my illness. Especially the longer goals, they often both include aims and means. And we often experienced that there were more than one goal in one. And that challenged the use of the ICF linking rules, as it was difficult to find the most important goal in each. Some goals are often easiest to link to the ICF, like the bra, but it gave narrow information on the patient. The other goal, like cooking, gave us more information on what's meaningful for the patient and the impairment that must be overcome to achieve it. And that led us to the question, what is a good goal? What is a good goal? That raised another question. What is the purpose of a goal? Is it to motivate the patient? If it is, there's no limitation on how to describe it. Is it to remind both the patient and treatment provider of the rehabilitation aim? Then the goal has to be formulated in a way that guides us into a deliverable and accessible content. Or is it to secure shared goals? If the goal is truly shared, it must be room for negotiation and modeling. Or is it to guide the professional to an easy overview for the patient's goals? In that case, the underlying impairment is very helpful. I'm afraid that my organization does not differ that much from many other organizations with the same work with rehabilitation. We haven't discussed the purpose. And now we have to go home and address that question that the ICF linking gave us. What is the good question? What is the advantage and disadvantage of a purpose? We'll do so, and I hope you're encouraged to do the same.
Thank you to both of you for this interesting talk and your thoughts about goals. Are there any questions? So then I have one question. There are 4 questions about the purpose of a goal. Do you have any idea about how to go forward with a further study to explore your questions?
Kind of. Kind of? Yeah, no, I'm hoping to do a PhD on goal setting at Sarno. Then I'm ready. Yeah, yeah. No, so we have a lot of work with all the professionals working at Sarno, because they've gotten. I mean, it's not. It's a kind of a new topic to look into goal setting, and a lot of people are interested in it now because it's very difficult. So, and also using the ICF has been an eye-opener. So I think that's our next step. So this was the first step, and next step will be also to work with the professionals and how can we actually move forward and have maybe more, ask them all these questions and have a good discussion about it. Yeah. Thank you.
So our last speaker is Sven Kottisch from our host institution, from the Medical School Hamburg. Yeah. So the floor is yours.
Hello, the last presentation. At first, I'm very happy to work together with my colleague Liane Simon at the medical school and also at the ICF Research Institute. I want to present you our results for the project ICF Medicine Phase 2. We developed a questionnaire with 7 closed questions and sent it to all the EICs in Germany. Therefore, we got the whole population of 1,000 institutions. And here are the results of our description statistics. Within our sample of 329 EICs, there are only 154 using the ICF. They use it in 3 different ways. 111 use the ICF as a framework attitude, 44 use it as the ICF checklists, and 69 use codes or ICF items for intervention plans. We go further on and analyzed the data by correlation statistics. Now I show you the results of the inference statistics. There are several significant correlations within our sample. First, unidisciplinary institutions do not use the ICF at all. Interdisciplinary institutions use the ICF as a framework attitude. And if they use the ICF as a framework attitude, less employees use the ICF. You can see all these correlations are low, but they are significant at the alpha level of 5% because of the very large sample. Now I'll show you more correlations which are significant of an alpha level of 1%. At first, if they use ICF checklists, more employees use the ICF. It's logical, I think. And if they use codes of the ICF items for intervention plans, more employees use the ICF too. And if they use the ICF as a framework attitude, more ICF checklists are used. And the number of employees using the ICF increases with the number of training or traction classes per year. And the extent of using the ICF per child per year increases with the number of training or traction classes per year too. Here are our conclusions. The deeper implementation of the ICF, the more sustainable use in the ICF. And we expect an increasing amount of implementing the ICF during the next years. And there's a compelling need for special ICF instruments adapted to the daily routine of the ICs. Last but not least, we observe a strong need for ICF training and seduction classes. classes.
While I know
All
correlations
correlations
are not approved
for
causality. Therefore, we go further on with a mixed method design, the three-post design to prove our hypothesis. If you want more information, visit our poster number 33 in the hall. Thank you for attention.
Thank you, Sven. Are there any questions? Yes, Melissa.
Those organizations or EICs that decided to implement the ICF or use the ICF with codes or ICF or checklists, ICF-based checklists, what was the impetus for them to actually decide for this model of implementation?
That's a good question. Do you mind to speak in the mic for the people that listen?
Right.
Yeah. Sorry, I'm answering. Why do they use the codes or the item?
How did they come to the decision to do that?
Well,
that's a good question. Why they come to the decision to do that? I don't know.
We didn't ask them yet. That's the follow-up is coming now, and we didn't ask them yet, but that's the next question. Yeah.
The reason I'm asking you that is because I just ran the workshop with a very nice group of people on how to teach ICF to help administrators and decision makers. And one question is, how can we convince health administrators and decision makers, including education, why use the ICF or the biopsychosocial model in their environment and their organization? Yeah.
Maybe you see us next year. New information.
Thank you, Ben. So this was our last presentation in this session, and I would like to thank our presenters for their interesting contributions. And I'm going to hand over to Melissa, who will give us a wrap-up.
Show the slide for the dinner.
Sorry, first of all, I show you the slide with the address of our hopefully. So it's the Chili Club, and I think it's nearby.
Yeah.
Yes.
I understand that you go out the door and go this way, and it's on the left side. It's like a 2-minute walk. We're interested at 6:30 over there.
Okay, and don't we still have a poster, don't forget to take it with you.
So we had a very
exciting day,
and we're challenged with D115 listening. You were able to apply your attention functions and B100
for higher level cognitive functions
to
D106 focus attention. And I hope that the many presentations was able to stimulate your 152 emotional function and support your D3 communication.
To improve your D730.
To improve your D730 to 750, which is.
And we hope that the symposium as a facilitator, not a barrier,
was a facilitator
for your work with the ICF,
for your work
and inspired
for these 100
about the ICF,
applying knowledge about the
in
ICF
your work.
In your work.
So concretely,
started out.
Leanna introduced
Leanna
Bosanchik from WHO.
He the WHO perspectives on the ICF and also
WHO reference classifications. Through
Peter
Dupla, he gave us insight on how to see ICF in standardized clarifications in early intervention. And also Michael
gave us an insight on innovations in ICF instrumentation
to address the new German law participation law. And then we had also some information about the HUFIC EIC, Education Implementation Committee, and also Matilda was a very animated, colorful person in functioning ICF. And then you were introduced to various different topics and workshops, and I hope you're very interactive and have a lot to take you back to your native countries. And last we had stimulating presentations this morning, as well as just the last hour. We hope from the organization committee of the International ICF Education Symposium that you enjoyed the day. So on behalf of Diana Simon, the chair of the symposium, Michele Kuhn, and also all of our contributors and helpers the whole day, including the wonderful students of MSH, that you enjoy the symposium, and we hope that you come to next year's fourth International ICF Education Symposium, wherever it is. Thank you very much, and we hope to see you at dinner.